you for joining us for episode 2 in this two-part CMEO cast series titled Getting the Jump on Tardive Dyskinesia, Real-World Strategies for Detection and Optimal Management. Today's episode is titled Making the Right Moves for the Long-Term Management of Antipsychotic-Induced TD, Evidence-Based Strategies to Improve Quality of Life and Patient-Centered Outcomes. This podcast series is supported by an educational grant from Teva Pharmaceuticals. I am Christoph Correll, Professor of Psychiatry and Molecular Medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell in Hempstead, New York. I'm an investigator at the Center for Psychiatric Neuroscience, Feinstein Institute for Medical Research in Manhasset, New York, and I also work with the Zucker Hillside Hospital, Department of Psychiatry, Glen Oaks, New York. I'm joined today by my esteemed colleague, Juhi Jimenez-Shahed, Medical Director of Movement Disorders, Neuromodulation, and Brain Circuit Therapeutics, and Associate Professor of Neurology and Neurosurgery at the Icahn School of Medicine at Mount Sinai in New York. Welcome, Juhi.
Great. Hi, Christoph. Nice to see you again and join you on this podcast.
Yes, so we're really pleased to present you with the second step. And to frame the discussion today, let me review our first learning objective. Our goal is that after this CMEO cast episode, you'll be able to incorporate evidence-based expert guidance on the use of VMAT2 inhibitors, vesicular monoamine transporter 2 inhibitors, to minimize the burden and improve quality of life in patients affected with tardive dyskinesia. Let's get started. Juhi, what do we know about the prevalence of TD?
So the prevalence of tardive dyskinesia is that it's still prevalent, right? So these neuroleptic medications, although we've changed generations, there's been improvements and changes to the, pharmacology and the pharmacokinetics of these different medications. Tardive dyskinesia sort of still occurs. So there were some meta-analysis type studies that were done looking at the incidence and the prevalence of tardive dyskinesia in the beginning of 2000 to 2015. And the estimated percentage of patients who were experiencing or diagnosed with tardive dyskinesia was about 20% for those individuals who were actually taking second generation antipsychotics. So that's a little surprising when we have in the past considered perhaps that these second generation antipsychotics are lower incidence or may kind of reduce the incidence of tardive dyskinesia, but it's not zero. First generation antipsychotic use in the same time frame, those patients had about 30% prevalence of tardive dyskinesia. And even amongst individuals who had taken first generation antipsychotics for the first time, the prevalence was about 7%. So the pooled prevalence of tardive dyskinesia amongst individuals taking first or second generation antipsychotics is about 25%. It's surprisingly high. So it's out there and we need to be looking for it. We also know through this kind of prevalence analyses and other analyses that have been done that the relative risk of developing tardive dyskinesia increases with kind of the combination of medications that you're taking. And again, as we mentioned, that even the use of the second generation antipsychotics is associated with significant risk of developing TD.
So this might be quite surprising to some to hear, like 25%, that's 1 out of 4 patients. That's not what I see in my clinical care. So it's important to notice that most of these data were in schizophrenia patients, whereas now a lot of the antipsychotics are used at lower doses, maybe not causing the risk factor associated extrapyramidal side effects like Parkinsonian symptoms or akathisia. And also that these studies that looked particularly for the TD symptoms didn't differentiate, was it mild or more severe? Moreover, as you mentioned, people who have never been on first generation agents and only took second generation agents lifetime had only, quote unquote, only a 7.2% prevalence. That's not zero, but it's clearly not 1 out of 4 people. As we said in the first component of this program, we need to look for it no matter what medication people are taking. Now, I realize that movement disorders are highly complex and the basal ganglia, I can't keep them all correctly connected, the different pieces. But can you tell us a little bit more about what the current theories are regarding the pathogenesis of tardive dyskinesia?
There's actually several different theories, and none is 100% proven, but really the prevailing theory has to do with dopamine receptor hypersensitivity. So if we think about dopamine signaling in the basal ganglia, as you were mentioning, we have the dopamine neurons that originate in the substantia nigra. They kind of connect into the basal ganglia and the caudate and putamen, and we have these dopaminergic synapses. So when the presynaptic neurons are releasing dopamine into the synaptic cleft, they diffuse and act postsynaptically on the dopamine receptors. When we are administering a dopamine receptor blocking medication, obviously that dopamine signaling really can't occur. And in the relatively short term of that dopamine receptor blockade, we might see things like Parkinsonism or tremors or symptoms of that nature. In the more chronic phase of dopamine receptor blocking, such as in a patient with long-term antipsychotic use, those receptors can actually become somewhat hypersensitive to the dopamine. They can be upregulated, and then that can actually facilitate the dopamine transmission, and you get more of an excess of movement, which is what we know as tardive dyskinesia.
So that's the prevailing one, but there's also oxidative stress, inflammation, too much glutamate, but we're not entirely sure what actually causes it. Bottom line, we need to dose as we said in our first program, we need to dose dopamine blocking agents modestly, that they are still good enough for the underlying condition, but not really treat them until they have Parkinsonian side effects and also akathisia. Now, relative to the goals of treatment for tardive dyskinesia, what should clinicians actually target?
Yep. So we've talked about the fact that tardive dyskinesia has abnormal movements associated with it, but that there's a number of other downstream consequences to having those abnormal movements. And one of the first and foremost concerns in treating TD is to allow the patient with an underlying psychiatric disorder to maintain stability of their condition. And so that can be achieved in a number of different ways. Thankfully, with some of the newer treatment options that we have available, there really does not need to be any compromise in the underlying treatment strategy for the psychiatric condition, but that should always be first and foremost in our mind about the care of these patients. Secondly, when we're approaching our treatment, we want to make the symptoms manageable, but not necessarily push treatment to complete resolution of symptoms. And the reason for that is, as with any medication, there are always potential side effects. And as we increase the doses, as we combine these medications and treatments together, we can increase that risk, and patients can experience adverse effects that make them not want to take the treatment. So we need to be careful. And in particular, with the group of medications that we're going to discuss, the VMAT2 inhibitors, there's risk of Parkinsonism and sedation. Thirdly, I think an important consideration is to really assess and monitor how patients are doing in terms of their quality of life and their daily functions. So yes, we can make movements less, but did that really achieve what the patient was hoping for, which might have more to do with things like their activities of daily living, such as their social interactions, their ability to perform their job, or to kind of function well in society without feeling embarrassed or insecure about their symptoms. And so we want to kind of have that more sort of comprehensive approach and consider all of those different factors in our treatment strategy.
That was quite comprehensive. So the American Academy of Neurology's recommendations for the treatment of TD, what do they actually entail?
So these recommendations came out in 2018. So this was soon after the approval of 2 new medications that are used to treat tardive dyskinesia, the VMAT2 inhibitors, and the first and foremost level A recommendation, which are those that must be recommended as treatment, are actually the VMAT2 inhibitors. And the 2 that are approved are deutetrabenazine and valbenazine, and those should be at least offered and mentioned and discussed with all patients who are diagnosed with this condition. A level B evidence for things that should be considered as treatment are things like benzodiazepines and ginkgo biloba. These are treatments that maybe function best as adjunctive medications. They probably aren't going to completely dampen a person's tardive dyskinesia, but may help and may contribute to improvements that are substantial and appreciable for the patient, and so they should be considered. Level C recommendations were those that might be considered as treatment. The first one that's listed there is anti-Parkinsonian agents, and I think the one that's being referred to is amantadine. This medication can be used to treat symptoms of Parkinsonism, but can also actually have benefits in hyperkinetic movements as well, such as are seen in tardive dyskinesia. Prior to the approval of deutetrabenazine and valbenazine was a medication called tetrabenazine, which really wasn't formally studied for treatment of tardive dyskinesia, but can still be used in that context. And so that might be considered. And so that fell into the level C recommendation. And then also in that category was deep brain stimulation. And so that may seem like a quite invasive treatment for something like tardive dyskinesia, but there really are some patients, especially those severe tardive dystonia patients that might be intractable or really refractory to some of the treatments. This can be an option that we might be able to consider. The last category of evidence that the American Academy of Neurology put in the recommendations was those that have level U evidence. And those are ones that have insufficient evidence to really support or refute. And I think they're worth still mentioning because I think there are things that we do commonly in practice. So withdrawing causative agents. This is something that might be beneficial in certain situations for patients, but we have to be absolutely careful about maybe potentiating the tardive dyskinesia, as we talked about, with dosage reductions that can actually unmask or worsen or bring on sort of a withdrawal emergent type of phenomenon. And similarly, when you are maybe considering switching from atypical to an atypical antipsychotic, or perhaps one that is less potent at the dopamine receptors, these can also lead to some disruptions and some instability in the level of symptom control. And so we want to be very careful about that. And I think that's why these are receiving sort of level U evidence in the American Academy of Neurology guidelines.
Thank you very much for this very nice summary. And we have to be cognizant that these levels depend on the quality of the studies and whether they were randomized controlled trials. So in the level evidence B, I suppose that the benzodiazepine is more slanted toward the tardive dystonia, so where it's very painful, you want to relax that, and not so much for the stereotypies. And ginkgo biloba, I've never used it. This is most likely based on very many Chinese studies, but there are no good Western data. I've never used it. Have you ever used ginkgo biloba, and does it work?
I have not used ginkgo biloba specifically, no, so I can't comment on any particular experience that I have.
Yeah, so I think it's in the guideline, but it's not something that we would generally use. And again, the data are based on non-Western studies. Now, the American Psychiatric Association also has treatment recommendations that are specific for TD. Can you review those for us?
Yeah, so these actually come from guidelines on the treatment and management of patients with schizophrenia. And very specifically, it is recommended in the guidelines that patients who have moderate or severe disabling tardive dyskinesia that's associated with antipsychotic therapy should be treated with a reversible inhibitor of the VMAT2, as we've been talking about. And this has been synthesized, and this recommendation was based on, as you've talked about, good quality clinical evidence and clinical trials, specifically for the compounds deutetrabenazine and valbenazine that were studied for the specific indication of treating tardive dyskinesia. And it's also based on some of the less robust clinical trials evidence of the parent compound, which was the tetrabenazine.
So again, for people with schizophrenia, we cannot remove the antipsychotic. So here, VMAT2 inhibitors are the go-to indication, unless you can maybe switch from a first or a second generation agent. And if you don't need to give an antipsychotic, you could potentially stop the underlying antipsychotic treatment, but you don't want to exacerbate the symptomatology. Now, when there are mild symptoms of TD, could you still give a VMAT2 inhibitor?
I think that it's certainly reasonable to consider. And, mild is going to be different for different patients, right? So I think one patient who, still is very functional and out in public, maybe working, might be very bothered by what we would consider a relatively mild degree of involuntary movements, versus other patients might be not very bothered by some pretty severe and prominent movements. So I think we always have to factor in that individualized decision-making for our patients and offer them treatments when they would like to have them treated.
Absolutely. So the impact is important, and also location. If somebody needs to speak a lot and they have tongue dystonia and can't have slurred speech, that's a problem. If they need to type or write or paint, and they can't do that. That's very impairing too. Now, we've talked a lot about VMAT2 inhibitors. How do they actually work?
So VMAT2 inhibitors are very distinct from dopamine receptor blocking medications, although they both block dopamine transmission within the central nervous system. They do it in a very different way. So VMAT2 inhibitors are actually located, or their location of function is actually within the presynaptic neurons. So where those neurons are manufacturing dopamine, the VMAT2 receptor is actually where it's a transporter that is required to incorporate the dopamine into a synaptic vesicle. And once it's incorporated into the synaptic vesicle, then the dopamine can be released into the synaptic cleft and then diffuse postsynaptically to act at the receptors. So what the VMAT2 inhibitors actually do is block the uptake of that dopamine into the synaptic vesicle. And by doing so, it actually gets fairly rapidly depleted by monoamine oxidase in the cytosol. And these drugs are sometimes actually referred to as dopamine depleters for that reason, because you're actually kind of lowering the level of dopamine in the presynaptic neurons. And this is an important distinction, that it's a presynaptic site of function, because this is actually why we can use these medications to treat tardive dyskinesia, which has, as we said before, a lot to do with postsynaptic receptor dysregulation.
So people might think this is very new, but they are actually most likely familiar with the first irreversible VMAT2 inhibitor, and that was reserpine, one of the first antipsychotics ever, but it depleted everything and for weeks and weeks on end. So people got Parkinsonian side effects. They got also akathisia, didn't have psychosis anymore, but got very depressed and suicidal. So this wasn't a treatment option. And now we have these reversible agents, deutetrabenazine and valbenazine, that don't cause this severe dysfunction and are much better tolerated than even tetrabenazine that they were somewhat derived from. So the AAN and APMA both recommend valbenazine and deutetrabenazine. So what are the similarities and differences among these two approved agents?
So these medications, as you mentioned, they were both derived from the parent compound tetrabenazine, but they're sort of derivatives of that medication in slightly different ways, which have impacts on their, not only their pharmacology, but also their pharmacokinetics. So deutetrabenazine is deuterated tetrabenazine, and that doesn't mean that it has any kind of radioactive or anything. I think some people get a little concerned about the terminology there. But basically, it's just a little bit of a heavy hydrogen. And what it does is it slows down the metabolism of the compound. And so it increases the exposure to the medication and actually allows the dosing to be twice daily instead of the 3 times a day that we would typically have to do for tetrabenazine. So that's one kind of key difference. Valbenazine is actually a purified prodrug of the most active enantiomer of tetrabenazine. And so they've really, you can think of it kind of as a purified form of the tetrabenazine. And this has a much longer half-life and actually can be administered once daily. So that day, the number of administrations in a day is one key distinguishing feature between the two medications. The dosing schedule is also a little bit different. Deutetrabenazine, you have the opportunity to start at a low dose and titrate to efficacy and titrate if needed to tolerability or best tolerability, whereas with valbenazine, you have 2 main doses of the medication, which either the patient takes it or it doesn't. That sometimes is easier in terms of getting a patient onto the therapy. So you have some choices there in terms of how those play out in terms of the actual treatment for a patient. Another differentiating feature is how these drugs are metabolized. Deutetrabenazine can be influenced by patients who are also taking CYP2D6 inhibitors, or maybe if they're a poor CYP2D6 metabolizer. And so we have to be cautious with some of the additional medications that these patients are taking in combination. Valbenazine does have some metabolism by CYP2D6, but it additionally can be influenced by CYP3A4 modulators, so a little bit wider distribution of potential drug interactions there. And, you know, I think the other key feature that sometimes comes up with these medications is whether or not they carry a black box warning for depression and suicidality. The original medication, tetrabenazine, did. Deutetrabenazine does carry that black box warning, but only for treatment of patients with Huntington's disease. And so it's important to remember that in the tardive dyskinesia population, that black box warning is not there for either of the medications.
Now that's very helpful. Just for us also to remember, the CYP2D6 metabolized agents that we use psychiatrically are risperidone and aripiprazole. So here you may not want to go to the highest dose, and also fluoxetine and paroxetine, as well as bupropion. 2D6 is a small road in the liver, so even a little bit of blockade can elevate each other's blood levels, whereas the 3A4, you need to block much more. And then in terms of the dosing, as you mentioned, twice a day dosing for deutetrabenazine, once a day for valbenazine, and you go in multiple steps over weeks from 12 milligrams BID dosed to up to 48 milligrams altogether, which gives you a broader dose range, but also a longer time to get there. Whereas after 1 week, you can go from 40 to 80 with valbenazine. So these are differences. Also, you don't need to pay attention to food with valbenazine, but it should be taken with food with deutetrabenazine. Just for the audience, because there was a lot of information to get some of the highlights. Then what about the adverse effects?
So these are medications that are actually, in some ways, pretty well tolerated. As we mentioned, they also have impacts on dopamine functioning, and so to a certain extent, they can have some similar side effects to dopamine receptor blocking medications, such as fatigue and somnolence and sedation. So those should definitely be watched for. Aside from that, deutetrabenazine has had, kind of been associated with a smattering of other relatively minor side effects, including things like diarrhea or dry mouth, urinary tract infections, constipation. So things that I think occurred in at least 4% of the patients were reported in the respective studies. Valbenazine, I think, similarly can cause the somnolence and sedation. There's some other potential concerns with this medication, including balance disorders, maybe some attentional issues, blurry vision that were not present in the deutetrabenazine population. But I think overall, pretty none of the sort of devastating long-term consequences that we might associate with neuroleptics.
Yes, and also not the problems we've seen with tetrabenazine, so not the depression, not the suicidality, and as you mentioned, no black box warning for the population that is affected by TD. Now, deutetrabenazine approved based on short-term trials, 12 weeks, because it takes longer to titrate up. Valbenazine approved because of phase 3 studies and phase 2 studies lasting 6 weeks. That's all in the package insert. But some of the recent data have focused particularly on the longer duration of treatment, because we don't treat people for just 4, 8, or 12 weeks with these agents, since the longest term data have shown once you remove the VMAT2 inhibitor, the movements come back. So can you tell us a little bit more about some of the recent data on the efficacy of deutetrabenazine?
I think one of the interesting studies that came out most recently looking at the long-term treatment effects of deutetrabenazine were looking at age factors. So individuals were divided into whether they were under 55 or 55 and older, and then their responses were evaluated over the 145 weeks of long-term follow-up data that occurred in the open label extension for this medication. And basically it boils down to the fact that there did not appear to be an age difference. And so our younger patients as well as our older patients were able to derive similar degrees of benefit, and that degree of benefit was sustained over the course of the long-term evaluation. And this was not only just based on the Ames evaluation, but also looking at the percentage of patients who had at least a 50% improvement from baseline. So there really did not seem to be any indicators there that patients were responding very differently to these medications. And then lastly, when you even asked patients themselves how they were doing and how they would rate their impression of change since starting the medications, older and younger patients alike were relatively equally experiencing and reporting the same degree of benefit. So it's very reassuring that not only our clinicians can measure it and see it, but then also the patients themselves are reporting the same.
And it's also reassuring that people who are younger, who get the tardive dyskinesia, or who are older, are helped in equal ways. As we've seen in previous analyses, that it didn't matter whether people suffered from schizophrenia or had a mood disorder, depression, or bipolar disorder. Again, each of those groups can benefit in a similar degree, as the other diagnostic group from VMAT2 inhibitors. Now, what have we learned about recent data with valbenazine?
So valbenazine similarly had open label extension studies going out, in this case, up to 48 weeks. And we saw that patients who were treated either with the 40 milligram dose or an 80 milligram dose, or perhaps started on 80 and reduced to 40, again, all of these patients continue to experience benefit in the long term. And we always have to take these data with just a little bit of caution. This is true for the deutetrabenazine studies as well. The numbers of patients who kind of continue into those more lengthy phases does diminish a little bit. And so we have to kind of take that into our consideration. But across the board, patients were largely maintaining the degree of benefit. And same thing here. This was not only reported by the clinicians, but then also reported by the patients. And actually, the percentage of individuals who were reported by their clinicians as seemingly normal and not ill at all, or maybe only borderline ill in terms of the degree of their tardive dyskinesia, maybe actually inched up a little bit over the course of the long-term follow-up. And so this is an interesting phenomenon that should also give us some reassurance that patients can continue to derive significant benefit as they stay on the medication in the long term.
Great, thanks so much, Juhi. So that was a great overview of the efficacy and safety of some recent data with deutetrabenazine and valbenazine for the management of tardive dyskinesia. Obviously, it's important to assess TD, as we discussed in our first part of this two-part series, in the patients that take antipsychotics. We need to monitor ongoingly as well. And now with the pandemic, it's been hard to always see patients in the office. We might have to resort to telemedicine and telehealth, but that doesn't excuse us from looking for these movement disorders. We can ask patients to open their mouth and stick out their tongue. We can ask them to move a bit back from the computer or their handheld device and show the hands and give us an account of whether they feel restless, whether others have commented on their movements, and then also regularly reassess patients for a potential tardive dyskinesia occurrence when using the aims that we've discussed previously. Anything you want to add about the monitoring part, Juhi?
Yeah, no, I think you're quite right about the telehealth. We said before that tardive dyskinesia is a very visual thing, so you have to have eyes on the patient. And I think you might want to consider a little bit the different types of telehealth approaches that you're using in your practice. Some people may benefit from just the telephone evaluations, but when you're really concerned about risk and assessment of tardive dyskinesia, the video-based assessments are really going to be the preferred way. But I find in my practice, not only in terms of tardive dyskinesia, but a number of other movement disorders, actually, that we can be quite effective in our ability to assess patients and determine what's going on from a movement standpoint by these video telehealth appointments. So definitely a strategy that can still be useful despite the pandemic, as you mentioned.
Juhi, in our first part of this program, we talked about collaborative care. Maybe we can just review briefly how neurologists, psychiatrists, other mental health care practitioners should collaborate in making sure that people with tardive dyskinesia get adequate care.
Yeah, we mentioned kind of collaborating with the patient in terms of making that sort of comprehensive, and collaborative treatment approach. But I think it's important to collaborate together with the healthcare providers that are working with the patient. And I, as a neurologist, may get patients for evaluation for tardive dyskinesia from a variety of different referral sources. It might be the patient themselves who has noticed some involuntary movements and want to be evaluated. I might get the referral directly from the psychiatrist asking, what's the appropriate diagnostic and treatment strategy here? Or maybe it's another healthcare practitioner that has seen the patient and is concerned about the abnormal movements that the patient is experiencing. And so I think, a lot of times there's just questions about what's going on. And for that reason, it's absolutely essential to communicate. And I always make sure that before my patient has left the office, that I either have the name of their primary care physician or their psychiatrist or other mental health practitioner that they're seeing, so that I can communicate with them, send my notes, pick up the phone, call them, talk about what I think is going on. And also to tell them that I believe that there are appropriate treatment strategies for these patients. And I think, the other healthcare providers working with the patient are often quite appreciative of that communication, so that there's some sense that that there are not only that there's a diagnosis, but that there's a treatable diagnosis, and that we can work together to ensure, again, as we talked about, that the psychiatric illness stays stable, that the treatment needs are being met, and that patients are being appropriately monitored with their treatment interventions. And I think that's absolutely essential, and that's one of the most important things that I try to incorporate in my care. And I think it never hurts to have more individuals who understand what's going on with the patient. So whether it's the patient, whether it's their care providers, whether it's the facility that they're at, so that everybody's kind of in the know about what's going on and how to manage the condition.
So communication is clearly key. In addition, personalization of care is key. Can you tell us a little bit about how that applies to the management of tardive dyskinesia?
Yeah, we've talked a little bit about this. I mean, I think it starts with recognizing that the condition exists, and then you communicate that with the patient. Perhaps you do the deeper dive into the structured assessment protocol and actually make the diagnosis. If you need to refer the patient elsewhere to actually have that diagnosis made, that's perfectly fine, but I think important to do so that there's a clear understanding. Documenting the severity of the symptoms, which might be different from person to person and certainly might have different implications for treatment strategy. We want to make sure that patients understand the breadth of treatment options that are available, and also to discuss that with their caregivers and other care providers. And then we've talked a little bit about how we can modulate other features, not just treating the condition, but if there are patients who can safely be tapered off their current treatment, if alternate therapies are available, maybe patients who can be switched to another second generation antipsychotic, maybe patients whose dosages can be reduced. These are all long-term strategies to consider. They may not be applicable to every patient, but certainly to consider them is one way to personalize the care for an individual. And then lastly, we've talked a little bit about the different choices that we have with the VMAT2 inhibitors and how that can be individualized to patient needs or patient preferences. So we have several ways that we can do that.
That was a great summary. Now, you talked about a team approach that's important. What are some of the barriers that you might have encountered, and how have you overcome them?
So the, getting the history is sometimes the first barrier that we have to work a little bit. And I think when you are familiar with tardive dyskinesia, know what the phenomenologic manifestations are, and have that index of suspicion, sometimes you have to work a little bit to get the history. At least on the neurology side, I find myself having to do that sometimes. And so I will sometimes send patients to the pharmacy and say, get the records of the last 3 years of medications that you've taken and bring them to me so I can look and see. And I've been surprised at some of the stuff that patients maybe don't recall or didn't know carried the risk of developing tardive dyskinesia, whether it was metoclopramide. I had another patient who actually was from another country and had been taking cenerazine and flunarizine, which we don't even use in the United States, but they had exposure, and that was the likely cause of their tardive dyskinesia. So I think a little bit of detective work for some patients. We talked a little bit about sort of the importance of communicating, and sometimes a barrier can be having that effective communication with the mental health treatment team. And I've done different things in that regard. I've tried to pick up the phone. I've tried to send email. Sometimes I'll just give an after visit summary to the patient with some clear instructions. Please talk to your psychiatrist about these options. I'm concerned that you have tardive dyskinesia, and have the patient help facilitate that communication. So those are some, hopefully some helpful strategies that people can think about using. I think within the office, itself, I have a nurse practitioner, I have administrative staff, and having them understand this condition and the treatment options. And then not only that, but also understanding the sort of administrative side of the paperwork and the ordering specifications for these different medications so they can appropriately follow up. And certainly from the nursing side, if they're screening phone calls, to be aware of what the potential side effects of these medications are. And so a little bit of education in our own offices can often go a long way in making sure that patients are being managed appropriately and monitored appropriately.
Thanks so much for sharing some of the key points of your clinical practice when managing patients with TD and having this team approach. Now, we're approaching the end of this second part of our program. Would you like to make any concluding remarks, Julie?
Yeah, I think what's really been, kind of amazing is to see how well patients can do when they have an appropriate treatment strategy. And I think, if anything else, the opportunity of having these medications available for patients is that we get to talk about it and get to reassure our patients and improve their quality of life with the appropriate treatment. And so important that we know how to assess it, that we have an index of suspicion in the appropriate patients, but then that we take that extra step to actually offer the treatments and get the care coordinated for these individuals.
Excellent. Julie, thank you so much for a very informative discussion on the pathogenesis of tardive dyskinesia and the role that VMAT2 inhibitors can play in the long-term management of antipsychotic-induced tardive dyskinesia. Let's summarize with our SMART, or specific, measurable, attainable, relevant, and timely goals. That is what we hope that you, our audience, will take from this presentation and apply to your practice. We hope that you will, 1, consider the pathogenesis of TD and the role of VMAT2 inhibitors, vesicular monoamine transporter 2 inhibitors, that's valbenazine and deutetrabenazine, approved by the FDA, in reducing the burden of TD and improving quality of life of our patients that can have quite reduced quality of life due to the abnormal involuntary movement. We need to also routinely monitor at-risk patients, those taking first as well as second-generation antipsychotics for tardive dyskinesia as part of our routine regular care, and the effectiveness of treatment in those diagnosed with TD. And we also hope that you will now be able to individualize the management of TD using appropriately, when necessary, VMAT2 inhibitors. Thank you for joining us today for episode 2 of our 2-part CMEO cast series. To view an additional episode on using measurement-based care to improve the early, accurate detection of tardive dyskinesia, please visit the Neuropsychiatric Hub at www.cmeoutfitters.com. Thank you so much, Julie, for joining us today. It was really a pleasure talking to you.
My pleasure, Christoph.
Both episodes and a wide variety of education and resources on neuropsychiatric disorders for both healthcare providers and patients are available on the CME Outfitters Neuropsychiatric Education Hub. Julie, thank you again for joining me today.
My pleasure, Christoph.
And I would like to thank you, our audience, for joining us. Be safe and take care of yourselves so you can provide the best care for your patients.